Hi everyone, my name is Shivani Gupta, and today we're going to talk about pediatric obesity. The objectives for this talk will be to define obesity, review the epidemiology, review the etiology and complications of obesity. We will go over how to assess an obese patient, and then we'll briefly talk about some treatment options as well. So what is obesity? The Obesity Medicine Association defines obesity as a chronic, progressive, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, which results in adverse metabolic, biomechanical, and psychosocial health consequences. In pediatrics, we use BMI percentiles to categorize weight status. And you can see from this chart here that when you have a patient in the 85th to 95th percentile for their BMI, they are considered overweight. And when they're in the 95th percentile or greater, they are considered obese. But it doesn't quite stop there. We do have classes of obesity, and it's divided into class 1, 2, and 3. So you consider class 1 if you're in the 95th percentile, and you consider class 2 once you hit the 120th percent of the 95th percentile. And then you're considered class 3 when you're in the 140th percent of the 95th percentile. In adults, classified here by our BMIs, and for BMIs that are greater than or equal to 25, you're considered overweight, and obese if you're over 30. And then further divided into classes 1, 2, and 3 based on a BMI between 30 and 40. In terms of the epidemiology, this was a graph that I took from the CDC website, and it does a really good job of depicting that in adults and in children, the prevalence of obesity has been uptrending, up to 18.5% in youth. So going along with those same years of 2015 to 2016, the prevalence of obesity was 13.9% among 2 to 5-year-olds, 18.4% among 6 to 11-year-olds, and 20.6% among 12 to 19-year-olds. You can also further classify it or break it down into race. So Hispanics and non-Hispanic Blacks have a higher obesity prevalence than non-Hispanic whites. And you can see by the percentage breakdowns that it's at least over 20% versus under 15% for non-Hispanic whites. And it is also true that children that come from low-income families are also at a higher risk for obesity. What about the causes? So as you can see from this picture here, there are several causes that can play a role into obesity. And it doesn't have to be just one of these. So one of the main causes that I think is most common is environmental. So overeating, eating unhealthy foods, getting up in the middle of the night to eat, drinking sodas, drinking lots of juice, things like that. But there are also other things that can cause obesity as well. And one of those things are also syndromes. So I think the top 3 are probably the ones that are the most common to us. So Prader-Willi, Bardet-Biedl, and Fragile X. But, and I'll briefly talk about some of the ones that are a little bit lower on the chart as well. But you can see that with a syndrome called congenital leptin deficiency, you have intense hyperphagia. With POMC deficiency, you have hyperphagia. So, and this is not a comprehensive list by any means either. This is just an example for you to take into account that if a patient comes in and sees you and has one of these syndromes, that it may not just be environmental, that it may actually be their genetic syndrome as well. And here's a picture that talks about some of the receptors. So when you have your satiety signals that are going through your neuron, of course, you're going to need some receptors and other signals. So, and if you have a lack in any of these things, then you're going to be more prone for obesity. And one of those being the MC4R receptor, which I'll get into in just a second. But the other one that I really wanted to make sure to point out was this one over here on the left, this LEP or LEPR. LEP is leptin, and this is its receptor. And so if you have a deficiency in its receptor, then leptin will not be able to act. And leptin is a hormone in the adipose tissues or cells, sorry, in the enterocytes of the small intestine that help regulate energy balance by inhibiting hunger. So again, here's the MC4R receptor, which is the melanocortin-4 receptor. And if you have a mutation in it, it's actually the most common monogenic form of obesity. You can have increased linear growth in final height, you can have increased fat mass, and severe hyperinsulinemia. The prevalence is about 0.5% to 5.8% in children. And you can actually have pretty early onset obesity, really as early as age 2. And then here's the leptin or the LEP receptor mutations, which can cause early onset obesity, hyperphagia, delayed puberty, and abnormal immune function. So there are also other hormonal causes as well. This is kind of more along the lines of endocrine causes. So hypothyroidism, growth hormone deficiency, and Cushing syndrome. And this is not only Cushing syndrome within your body producing excess cortisol, but also exogenous causes as well. So keeping in mind that patients who are on steroids, for example, may have weight gain. So going along the lines of medications, there's actually quite a few medications that can cause weight gain. And so I think that this is really important to review a medication list with a patient to see if any of their medications that they have been on for a long period of time or recently just started could be contributing. So there are antidepressants, Zoloft or sertraline, amitriptyline, nortriptyline, and paroxetine. You have your mood stabilizers, lithium, valproate, carbamazepine, and gabapentin. And then your longer list will include your antipsychotics. So mirtazapine, risperidone, quetiapine, Haldol, clozapine, just some examples to keep in mind. So what about your complications? Now we know that there's a long list of complications that come from obesity, so I divided it into GI and non-GI complications. For your GI complications, you have, of course, your non-alcoholic fatty liver disease or steatohepatitis or NASH. Your patients who have obesity can have a higher risk for gastroesophageal reflux disease, cholelithiasis or gallstones, pancreatitis, and functional abdominal disorders. And then your non-GI complications include dyslipidemia, diabetes, hypertension, sleep apnea, PCOS, pseudotumor cerebri, and reduced quality of life. Of course, falling under that reduced quality of life includes things like depression and anxiety. So how to assess a patient with obesity? I think that this is really important, especially if you're meeting them for the very first time. So you want to start off with a really good medical history. And with going along with that, you really want to get into, when did this start? When did they really first start to notice that their weight was increasing or increasing rapidly? Did they have any triggers for weight gain? Did they have any, sudden events in their life, such as parents getting divorced or changing to a new school, moving to a different city or state, anything that could trigger any sort of changes in life? Past weight loss attempts, did they try any diets at any point, and were they helpful? And that'll give you an idea as to what's worked for them in the past versus what may help them now. What sorts of physical activity did they do, and was it helpful? Were they in sports? Are they in sports now? Getting a really good diet history and eating pattern. How many meals a day are they eating? Take a really good detailed history. What exactly are they eating? What are their portions? Are they getting up for seconds or even thirds? How often are they eating fast food or out at general restaurants? Do they binge eat? Do they get up in the middle of the night to eat? And on your slide, you'll see here that I mentioned family meals. It's been shown with multiple research studies that family meals can be a protective measure against childhood obesity. And what do I mean by family meals? That means sitting together around a dinner table with your family. It means helping prepare the meal with your parents. And really, they think it's beneficial because you're getting good modeling behavior from your parents in terms of portion control, in terms of good quality of food, and really just good conversation. So getting a history about their physical activity and sedentary lifestyles. Are they the type of kid that wants to sit in front of the TV and watch movies or play video games, or are they getting outside and playing with their friends and or riding their bike, walking the dog, things like that? We want to get a really good review of systems to see if they have some of those complications that we briefly went over a few minutes ago. So are they having any belly pain? Are they having any burning sensations in their chest? Are they having any headaches? What about their family history? Or is this something that runs in the family? Is there cardiovascular disease in the family, hypertension? All of that will be really important to really get to know your patient. Now we get into your exam. So of course, the first thing you want to do is plot your weight, your height, and your BMI on the CDC growth chart if they're over 2 years old. But you're going to use the WHO growth chart if they're under 2. Of course, measure your blood pressure, pubertal staging, papilledema, which of course I know this is going to be hard in a standard office, but I think getting a really good history about vision changes or headaches will give you a clue. Thyromegaly, hepatomegaly, or splenomegaly. And lastly, skin. So acanthus nigricans is a sign of insulin resistance. And so that's a very good clue before you even get labs on your patients. And speaking of, what about your diagnostic evaluation? So you're going to want to start with some labs, and they don't necessarily have to be fasting, but it is preferred, especially if you're evaluating for their complications of obesity. So you want a fasting blood glucose with an A1C, a lipid profile, getting your liver tests, and your thyroid studies as well. So if you have suspicions, so let's say your patient has elevated transaminases in the setting of high BMI, then the next thing you may want to do is evaluate for fatty liver disease. So you may start with an ultrasound to evaluate the anatomy, just to at least make sure that that's normal and that you don't have any other possible chronic liver diseases that are playing a role in your lab abnormalities. And then you may want to get an MRI with elastography. It's a little bit more sensitive in evaluating for fibrosis, but really just your imaging alone is not going to be enough to at least diagnose and stage fatty liver disease. And so the best way to be able to do that is going to be your liver biopsy. For diabetes, you want to get a fasting glucose, possibly a 2-hour glucose tolerance test, and of course your hemoglobin A1C. If your patient has any complaints of snoring, pauses in their sleep, daytime sleepiness, which of course they may not notice but other family members might, then you may want to think about a sleep study. And now we'll briefly go into treatments. So having a multidisciplinary team is going to be really important. At our Center of Healthy Weight here at Nationwide, there are 4 main team members that they have. And so one, of course, includes the physician. One includes the RD, or the registered dietitian, that meets with them pretty frequently, or every visit, to talk about the changes that they've made in their eating and to help provide that education. The third one that's a part of their team is a physical therapist, and not just to assess from an injury standpoint, which of course will be important as well, but to also give them exercises that the actual patient will be able to do to keep themselves active. And so they do a really good job in meeting with the patient to provide exercises that are tailored towards the patient. And then the last one is a social worker or a psychologist that can really help them with the behavioral part, but also because the process is stressful. Losing weight and consciously changing your life in that way can be very challenging. And so it's really important that they get the chance to be able to express some of those emotions. Motivational interviewing is also very important. So you can talk a patient's ear off about how they need to lose weight, how they need to be healthier, but until they are motivated to make any changes, it's really not going to be successful for them. And so here are some of the nutritional interventions that can be made, pretty early on. So you can encourage families to provide 5 or more servings of fruit and vegetables per day. Decrease screen time to less than 2 hours a day, in making accounting for 1 hour during the day for moderate to vigorous activities outside. Limit eating out in fast food, having more of those family meals together at home. Choosing more nutrient-dense foods, but less energy-dense foods, so less carbohydrates. Portion control, and you can really talk about my plate as a part of that, and low glycemic index. So, of course, that's going to be the first step, are your lifestyle changes, and that's kind of what we just went through. But there are a couple of other stages as well, and so one of those are going to be actually supervised dietary changes or diets, really. And one of those is called the protein sparing modified fast, which is a low carbohydrate, high protein, reduced calorie diet. Patients can be instructed to have calories of only 500 to 800 a day. Of course, that's not really going to be sustainable in some of our pediatric patients, but just to let you know that it can be just even as low as that. And it helps increase satiety and suppress appetite while preserving lean body mass. Without the carbohydrates, your body will have increased lipolysis occurring, which leads to fat breakdown and weight loss. And through that, you're going to produce ketones, which will further suppress the appetite. And here are a couple of studies here that have shown that the protein-sparing modified fast, or at least a revised protein-sparing modified fast, has been helpful in adolescents to help them lose weight. Now, medications can be used as well. Now, these aren't medications that are used on their own, regardless of what they eat or regardless of how active they are. These are used only as adjunctive treatment. So one of the medications is metformin. So we all know it as a medication that helps with diabetes. And it's not FDA approved for weight loss, but since it decreases hyperinsulinemia and insulin resistance, it can lead to decreased adiposity in obese adults. And it can provide a modest reduction in BMI when, again, combined with those lifestyle changes. It may have a role in prediabetes or in a patient who has a strong family history of type 2 diabetes. It may even prolong the duration of time onset of type 2 diabetes. And so you really have to think about when you think that a medication like metformin will be appropriate. Of course, you're not going to use it on every obese patient that walks through the door, but if you have signs of insulin resistance, such as acanthosis nigricans and abnormal labs, then with a family's history of type 2 diabetes, you may be more inclined to use it if some of your other previous things don't work, such as your lifestyle changes or some of those diets. And again, here are a couple of studies that show that it has been helpful in obese adolescents. Another medication is called topiramate, or commonly known as Topamax, also not FDA approved for children to lose weight. It is an anti-epileptic and also used for chronic headaches, and it may control cravings. So again, if you think about a patient that has epilepsy or that is complaining of chronic migraines, things like that, Topamax may be something that you can use for multiple reasons. There's also a medication called Orlistat, which actually is FDA approved for children that are at least 12 years old. And what it does is it inhibits lipase. So you're reducing dietary fat absorption and your fats are not hydrolyzed. And so your body's not absorbing them. And so what happens, your body just excretes them. The weight loss is not super dramatic, but it does have a lot of side effects. Mostly GI side effects, abdominal pain, diarrhea, oily stools, things like that. So that can preclude patients from using it. And then lastly is bariatric surgery. So again, if you've exhausted your lifestyle changes, some diets, and you've even tried medications, let's say it's really not working, or your patient has continued to actually gain weight, then bariatric surgery may potentially be an option for them. But really only if their BMI is at least 35 with comorbidities such as type 2 diabetes or fatty liver, obstructive sleep apnea, things like that, or a BMI of 40 even without comorbidities. The vertical sleeve gastrectomy is the most common operation. And you have to be careful because your patients do have to be screened for micronutrient deficiencies before and after their surgery, and may even need lifelong supplementation for various vitamins. And so again, this is, of course, every surgery comes with its risks, and so you really want to save this as your last resort, but can, of course, be very, very helpful. Before your patients are able to go through with bariatric surgery, they go through a very intense diet for a few weeks to help with rapid weight loss before they can go through with surgery. But I won't go into too much details about that. But that's all I really had. Thank you guys for listening. Have a good day.